So good morning, everyone. Thanks for coming to listen to me. A lot of brave people here. It's a pleasure to be here and address many of my colleagues here. It's like preaching to the choir. They're here, they know me, but there's some people who are coming in. We're recruiting people. Good. I'm going to be very brief. I'll give a couple of slides on the HIV epidemic because there's another professor that will be addressing that at the end. And very briefly, one slide on hepatitis B and spend most of the time on hepatitis C, which I think we still need a lot to do here in Puerto Rico. These are my disclosures. So the outline of what I'm trying to address this morning is just mention briefly a couple of slides on HIV burden in Puerto Rico, very limited data on hepatitis B, probably related to the vaccine program, which has been very successful here. And we'll focus most of the attention on hepatitis C, the stats, the incidence and prevalence, because it's very interesting that the data in Puerto Rico is very sketchy. We do have, and we don't have, and we don't know what to do with it. And then I'll address a couple of the projects, both in the mono-infected and co-infected experience in Puerto Rico, and mention some, at the end, some of the estimates from the Polaris Observatory in terms of what may happen from 2015 to 2030 in Puerto Rico, and then a couple of slides at the end. So many people have seen this. It's a courtesy of Dr. Sandra Miranda, who is in the audience. Thank you very much. This is the data, and the data in HIV/AIDS in Puerto Rico is really flawless. It's very good. It's up to date. As you can see there, even though things have changed in terms of new cases and in terms of deaths, which is in red, and new diagnoses, the incidence, prevalence still, it's lingering in sort of a plateau, might be a little bit lower in the near future, but if we want to curtail the epidemic, we need to bring that prevalence down, especially with keeping people on treatment and suppressed. As you know, Puerto Rico stands in terms of prevalence and cumulative AIDS cases, 12th place among adults and adolescents diagnosed with the condition, 6th place, and this is data really recent, published a couple of years ago at from the surveillance report. 6th place among adults and adolescents, and 10th place among the highest number of cumulative AIDS cases. And as you may know, we are within the 48 counties and cities in the states with the highest percent of HIV cases and new cases and prevalence. And here's Puerto Rico in red, little one here among the first states, and therefore we're included in the plan of America from our President Donald Trump. I'm swallowing. So hepatitis B, I told you, is going to be very, very brief. There's very little data available from the Department of Health in terms of stats, incidence, and prevalence. As I mentioned, the mandatory vaccination program since the early 90s has been very successful and it has made the disease almost a rare one. There has been an 85% plus compliance with the vaccination, but as it has happened, and it was mentioned here yesterday, as in many places of the states, the vaccination programs are lingering. There's a lot of misinformation in the community, and it has dropped to 77%, and this is not good. So we need to do much better than that because, as we've mentioned yesterday, we have a great vaccine and we could really be curtailing this epidemic almost 30 years after the first vaccine came out on the market. In 2015, 29 cases of acute hepatitis were documented, 17 cases in 2016, 12 cases in 2017, and 6 cases in 2018, and that's all I have in terms of statistics. All cases are within the 30 to 70 age group. There were no infants or adolescents reported. So hepatitis C was a situation, and this is very close to my heart because after having spent 30 years in HIV, realizing that cure is there, maybe at the end of the corner, at the end of the tunnel, but still very inaccessible, Hepatitis C, we could do much better, and we have the tools, but we need to move the people to realize that. In terms of epidemiology, the prevalence is somewhat controversial. If we look at reports dating back 8 to 14 years, what has been published, some people say that Puerto Rico would be somewhere around the 2% prevalent, which is extremely high compared to many of the Latin American countries. And even San Juan, one of the reports stated that it was 6.3 per 100,000 individuals. The genotype distribution, as you can see there, is almost 80% genotype 1, as many places in the States and part of Europe. Genotype 2, 12%, genotype 3, 3.8%, and genotype 4, 2%. I think genotype 3 is coming around, and it's the recent data, it seems like we're having more genotype 3 than 2. The prevalence is significantly higher in males, 4% to 1%. Peeweeds, 60 to 85% of them have been infected. We don't have data from prison system, but it's supposed to be extremely high, anywhere from 35 to probably 60% plus, but that's unofficial. And there was an isolated reporting sample in 2004 that looked at almost 90,000 individuals with positive antibodies. And the problem is that we still don't have reflex testing as a mandatory. It's antibody, and we presume it's 70% being conservative of those individuals will be viremic, as you can see in the slide here. So we do have a problem. If we look at the estimated viremia, and this is from a report from a public health response from hepatitis B and C published in 2016 by Pajo, Latin America in general has an estimated viremia prevalence of 0.66%. The Caribbean, and for some reason it's not coming out. Okay. The Caribbean basin is somewhere around 0.53% viremia. Latin America and the Caribbean, 65%. So if you look all over, it's less than 1%, most of them. Total for the Americas will be somewhere around 0.73. So what's the numbers we have at the Department of Health from 2010 to 2015? This is the latest data that I was able to obtain. And as you can see, from 2010 to 2015, we had 11,334 cases reported. But as I mentioned, it's antibody and few of them are PCR. So we have to take this with a grain of salt, but basically, being sort of a pragmatic person in terms of 70–80% viremic patient, if we use a conservative estimate, we're talking about close to 8,000–9,000 patients with probably viremia. If we look by males and females, it's a 3-to-1 proportion in blue men's, in yellow or orange women, and the numbers are here in terms of years of report. Note that in 2015 there's still some data missing, and that's probably one of the things that the Department of Health struggles in terms of confirming the suspected cases because there's no PCR or viremic testing. In terms of year report by age group, you can notice that above 30 to 39 to 50 to 59, you can see that are the predominant in every single year. But then we have disaster struck us from 2016 to 2017, and then now 2019, the nightmare began. We were imposed a fiscal planning board, which turned out to be an economic disaster, as we all know. Irma, in small letters, skirted us on the northeastern part, but really made us very vulnerable, and a week later, Maria, and you can see Maria here, really took a big hit in all of us, and basically the island was stagnant for more than 9 months. And then we had this past July, we had a governor who was forced to resign, which turned out to be a political disaster. So it really has affected most of us because Puerto Rico are very fanatics in politics, and either you're blue or red, and if you don't say that, you're not my friend, and it's unfortunate, but I guess it happens everywhere. The last data we have from 2017 from the Department of Health, and 2017, remember that after September 20, things changed in Puerto Rico. with Maria. So this is most likely data from up till September 20, because I don't know how they were able to get information in October, November, December. There was no lights, there was nothing in Puerto Rico almost till December, or at least late November. So even at that time, there were 1,200 cases reported. Now again, these are suspicious, confirmed, but if we use the 70% sort of strata, we have close to 900 patients that were identified in 2017. There's no more data after this, at least that I was able to obtain from the Department of Health. By regions, the biggest city, the metropolitan area, had a higher number of cases, almost 300 cases, followed by Bayamón, which is really a huge city, and a lot of people love it, a lot of people hate it. And then Caguas and Fajardo, which are also, and Ponce, which are also big metropolitan areas, accounting for a big chunk of the reported cases. So efforts to do something between 2014 and 2015, there was an expert panel appointed by the then Secretary of Health to establish national guidelines on management and treatment. We followed, and I say we because I was part of that group, of that panel. We followed the ASLD-IDSA guidance template. We started with a pilot project, 3 centers within biggest cities, San Juan, Ponce, and Mayagüez, to treat both mono-infected and co-infected patients. The panel was supposed to meet at least 2 or 3 times a year to revise criteria, function, and performance, and we did. But then came 2016, and last we made, what we recommended was to include F1, F2 stages, because we already had treated with the resources that we had available, most F3, F4, and compensated cirrhosis. So what was done in the mono-infected patient? They were able to treat and complete at least 40 patients, mostly in the area of San Juan, 28 to 1 women, so it's still the ratio. It's almost universal, 70% were male. The age range group was an average of 54. And here are the remaining cases. 81% were genotype 1, genotype 3, I'm sorry. Genotype 3, as I mentioned before, seems to be getting now a refreshment course because it's kind of bumping up compared to genotype 2. And in terms of availability of drugs, they are all approved as FDA mandated, and including 8 drugs assistance programs, but the accessibility has been very, very minimal, unfortunately, especially for mono-infected individuals. Here are the patients that completed treatment, 12 weeks, all of them. These are mono-infected in Ponce, Mayagüez, and San Juan, and they were mostly treated with either Harvoni-based, also hospipir-based regimen, Harvoni, and other that completed treatment. 13 patients were F4, 16 patients F4 without cirrhosis, 10 patients were F3, and 1 patient didn't have any fibrosis. He was post-transplant, and they all completed treatment. And the best I heard from Dr. Torres, who's following the data, is that they all achieve SVR. What has been done with the co-infected? This is the other group, and these are luckier because we do have funding, federal funding for them, and Dr. Celeste Rodriguez has done a tremendous job with all the other individuals in the different clinics. We're able to treat from September 2015 to March 2018, close to 323 patients. With a mean age of 52, had an APRI score of 1.4. Males and females, females 24 to 7%. Interesting, there were more females in this data. 72% were treatment naive, almost 30% were treatment experienced. 62% had advanced disease F3, F4, with a mean HCV viral load of more than 8 million copies. And the different areas of treatment, San Juan was almost 60% of the cases, followed by Ponce and Caguas. These are the different stages of the staging of the patients. 47% were F4, 15 F3, and 24 F2. One of the things that we recommended, since we had treated most of the patients with advanced disease, was to open it up to F0 and F1. and this was just the last recommendation prior to the change of the new administration, and we haven't met again. So things have been lingering somewhat, but at least there's resources to treat this type of co-infected population. Here are the genotype distribution, which is pretty much the same as I mentioned before. Interesting to note that genotype 3, again, even in this population, is higher than genotype 2, and almost 80% with genotype 1. And the overall study results at that time, and this is March of 18, all of them completed the direct antiviral regimen. 72% were on a base sofosbuvir regimen, and there was a 97% successful SVR. So finally, I'm going to talk on a little bit of the overall projections by the Polaris Observatory. And I got this data, this meeting was supposed to be held in 2017. I got the data earlier in the year, in 2017. When I went back a couple of months ago to see if there was any update, interesting enough, now Polaris charge you to access the data. Before it was open, now they need sponsors and support, and unless you pay, you won't have access to the data. The only countries, as far as I remember, it was the United States. Like 4 states were paying, New York and 3 others. I think China, Hong Kong, and I don't know if it was Australia or someone else. It's the only data that apparently they are sponsoring. But anyway, the Polaris sort of projections are interesting because they go along with the WHO recommendations of the targets for 2030, which we've heard that it won't be achieved in most likely all of the countries, from what Dr. Cox mentioned yesterday in her talk. But I think it's still a stimuli to the countries to do the best they can to try to meet those targets, although they are probably not reachable at this moment with the access of service. And they basically base their estimates on the disease burden at the time that they do they cut the data. They use at that time they used the 2015 scenario, and they try to follow the same scenario as WHO in terms of reducing 90% of new infections, of diagnosis, and having at least 80% of people eligible for treatment, to reduce 60% or more mortality by 2030. So what's the estimate for Puerto Rico from 2014 and 2035? And this is taking for granted that nothing is being done, unfortunately, in general. Genotype A, 1B, and others, mixed combination, will probably achieve 80% of most of the genotypes. The target for new viremic infections, starting in 2015, close to 40,000 persons, with the estimate that they were able to tally, they were expecting a decrease, dramatic decrease to almost in the decimal numbers by 2035. But this is basically the base scenario. It is expected to remain pretty much unchanged, a little bit of a downward slope, although if we don't do that much, it'll be pretty much the same. In terms of patients treated, their expectations in green is that by 2020, at least 2,000 people had been treated, remaining almost stable for 4 or 5 years, then another peak by 2025 to 1,000 more, remaining then a plateau till close to 2030, when they expect that they won't need too much treatment. But if you look at the base scenario, it's stable because nothing is happening. Nobody's getting treated, basically. In terms of new infections, this is the base scenario in blue, and they were expecting a downward trend to probably in the close to 20, 30 new infections at the most by 2035. And the same happens with liver-related deaths and cirrhosis. No changes. The scenario can increasing because nothing gets treated, and they were expected to have a downward trend, according to WHO, to very low 20s or less by the 2035. So in conclusion, I think being politically correct, and this has been my speech to many of my colleagues and different clinicians and even the community, we have to engage as a country, as a civil society, try to get sponsored donors, policymakers, to trying to generate a political will and commitment to mobilize resources and reduce the diagnostic and medicine cost. And even though they've gone down, I think they need to do much better than that. I think countries should estimate resources required to implement the prevention, screening, and treatment strategies and their expected health, societal, and financial benefits, trying to reach domestic and international funding. I mean, there has to be more cross-networking if we want to achieve something. The development of prevention of HCV, screening, treatment, and strategic matrix, I think fits well into what we have learned from HIV and AIDS programs in terms of financial infrastructure, workforce efficiencies. And this is a must if we want to achieve something. I think with the new and short duration regimens of the DAA, we do have the potential to facilitate treatment and improve outcomes. But for some reason, a lot of people got treated in places like the States. Australia did a great job, UK, but now we're seeing like a plateauing, and we're still seeing new infections in terms of reinfections. The politically incorrect conclusion is that we do have the knowledge. It's easy to treat now. We've seen it in different trials, like ASCEND, that the community can take part of it. We don't need subspecialists as IDs or GI just for the very sick patients. We have the tools, strategies, and we have the modeling planning. There is an established infrastructure that we just need to pull in the plugs for hepatitis C. It can be utilized in many places. Prices have gone down, and generics are becoming available. We need to stop bureaucracy. There is and will never be universal pricing for drugs, unfortunately. So government needs to develop and implement sensible programs, but we need to do this as a whole. It's not only patients, it's not only physicians, it's not only politicians, although rarely they'll get involved. We need social, political, and patient advocacy. We need to do the cultural mingle, as I call it, but we need a will to execute. I think the moment is still now, but we have to stop the excuses. Thank you very much.